Really, my main point was on the second question. And it's actually, I suppose there's a point to what I'm saying, but I will express it as a question, largely for the advocacy sector that's here observing today, which is, I would quite like a bit of a tweak to add in the phrase, and public. Because it seems to me that simply to say patient implies there is a single concept of patient, and I think it's a much more diverse concept, at least that falls into the concept of the actual experience and the potential experience. In other words, what was it like for me? How did it feel for us? And what do I think it should look like? And they are two different questions, and I think it's quite difficult to balance both of them at the same time. So my question really would be, does what I've said resonate as a question that there are different perspectives that need to come from those who consume the delivery of healthcare, and not just the concept of patient as a unitary thing?
Let's ask our patient representatives here. What's your response to Alistair's question or observation? Does the public have a role as well as patients?
While they're thinking about it, can I just make a separate point which irritates me intensely?
No, actually. I'd like to hear their views on this one before we lose it.
I'll make sure Diana says her point, but it's this whole thing about what Niall said about, you know, in the foothills of data. If you go to any decent theatre nurse and say, my mum needs a hip operation, she'll tell you which bloody consultant to go to, right? And any anaesthetist will tell you who the decent surgeons are. So why have I got to wait for some bloody Mickey Mouse organisation to get up these foothills? Because actually my mum could be the one that goes to this next person that's crap at it. So I think there's something about using the data we've already got and the information we've got, rather than waiting for something that's perfect. I don't get it. Why are we all trying to protect those that we know are not very good?
Okay, very good
the
point.
The GMC particularly.
I'm sorry I tried to shut you up because it's a very good point.
No.
Right. Okay, Alistair's point. The public and the patients involved in regulation.
Yeah, I mean, I think that the public have been completely bamboozled by a lot of the things which have been going on, because, I mean, there's many people sort of making very clear pronouncements about what they say has happened, which isn't necessarily accurate, or, you know, it can be very confusing. So, I mean, I think that Neil Dixon is quite correct in saying that there are a lot of things happening at the moment in terms of the kind of data that we can begin to collect, and it's no point at the moment in trying to actually put this down to a fixed position, because things are moving very rapidly, they're changing very rapidly. And we don't need to put it in a box at the moment. We need to look at the potential that is there.
Yeah, I think there's a couple of issues. I think it's not just about the public and the patients. Actually, sometimes patients themselves will have very, very different interests. So, you know, the vast majority of elderly patients who are near the end of their lives, so people that end up dying in hospital, are actually admitted through A&E and don't feature in the kind of the 18 weight target. So they're going to get a very different priority and sense of what's important than the people who are admitted for elective care, which also forms a huge amount of a trust activity. And so I think you actually have to have some sense that, and it picks up Anna's point that was made earlier about some of the people who are most vulnerable are least able to make their voice heard themselves. And within the kind of, whether it's regulation or it's finance or all the different things that we debate and work on in terms of policy and healthcare, doctors don't all have to have their opinion made, and nurses don't all have to have their opinion made. They have a union that's very well funded that covers their issues and their interests across the board about all those different things. And I think patients need a similar, equally robust and capable organisation with as much funding as those equivalent organisations to make their voice heard in all the different issues.
Implicit in Alice's point is that the public should be involved in almost the third point around setting out aspirations for the future, how they would like to be treated if they ever got to being a patient. However, is there a role for aspiration when minimum standards are not being complied with? Frances, you've not had a chance to say anything.
I think Alistair's absolutely right. That you should, if I could go back to not answer your second question, but I put my hand up beforehand. the public need to be involved in it. And I think one of the things that we need to think about as well in the context of all the discussion we've been having today is what sort of regulatory system do we want to have and what's it going to cost? Because I think, and particularly that cost, because the bulk of the care is provided and it will be borne by people as taxpayers or as users of services in the sort of social care sector, because CQC regulates all social care as well as NHS and independent sector. So I think that it's almost like that's a bit of a sort of reality check that we need to have on it. But I think there's also the extent to which you expect and people want to be involved actively in the regulatory process. In another life, I spent a lot of time being involved, almost as a professional patient in regulation. And it was a real struggle for people like the GMC and other bodies to do that systematically. If the government, and here I'm not speaking for the Confed, had been robust in its approach to Healthwatch and really set up something that was the equivalent of Ofcom and the like, that operates for other regulators, we might be in a different position. But I think there is something in which most people expect regulation to work, and they're not particularly, they're only interested really when it goes wrong. And actually, a lot of people have actually got much better things to do with their life rather than get deeply embroiled in healthcare standards. So I think it's almost like that's a bit of a sort of, what's it going to cost? And to what extent can you actually expect people to play a really active role in setting those standards and making it work?
And is it going to add value?
Yeah, exactly.
Alan,
well, just to the second point, if I could just talk to that still. I think, and Alistair's tweak, I think it's exactly the right one about patient and public involvement. And of course, we do have the links, assuming the bill goes through, we will have Healthwatch. And Healthwatch England will sit in CQC, a bit like a cuckoo in a nest, I suppose, but it will pull through the experiences as people are able to articulate them across the country. And Healthwatch, local Healthwatch, will have the powers that you were referring to about people not unannounced, but as part of an inspection regime being able to go in. But from our perspective, from a CQC perspective, in terms of the regulatory process, I would say one of the most powerful components to our regulatory model as we're currently implementing it, and we did do this for the dignity and nutrition inspections, was to have people who've used the services, the consumers, the patients who've used the services, the 150 inspections that we're currently rolling out across mental health services for people with learning disabilities and challenging behaviours. The most powerful group, we've got all the professionals that we've recruited to work alongside the team of inspectors, but just as importantly and just as significantly are the carers that we've been able to recruit and the patients. I mean, it's difficult recruiting some of the patients because they were reticent to go back into some of these institutions, but it's a very powerful part. And for the inspections I've been on, I think the most significant contribution that you can take out of that sometimes is the messages and the contribution that patients and carers are able to elicit from those they speak to. It's really powerful stuff.
Having patients involved in the inspection processes
Yes.
enables patients to speak to each other.
It's very important.
Okay, very good. Point you on, sorry, it was a while ago. You might be on none of these points.
Terence Stevenson, the Royal College of Paediatrics. Now, I wanted to move on. You asked about question 3.
Yeah.
I think if standards are too aspirational, they just get ignored. They're so far removed. So I think the right answer is to have stretched standards. If you can move the worst quartile up to the best, we would save thousands of lives tomorrow if just the worst performing providers did as well as the best currently in the UK. And I think that's what our college and other colleges try to do, is set standards that are demanding, but are not so far removed from reality that that practitioners just say, well, that's just these people are in a different world from us.
Is it better then for organisations to set their own aspirational stretch than have this done as some national standard that everybody should aspire to?
I think it's best to be set nationally, not by all organisations to set their own standards. That's.
I want to put a slightly different view. I think it does depend on the robustness of the standards that you've got. Because what I heard this morning around the nuclear industry was something around the culture of continuous improvement.
Yeah.
And actually, I might be as interested in knowing that the organisation is getting better than how much better they're getting. So I would like to get into that question something around the speed and direction of travel, as well as where they've got on the continuum.
So loads of hands up here. Lady at the back there.
I'll stand up so you can hear me. I think that there is evidence that where you get the profession to set the standards, and I'm not just talking about the medics, I'm talking about in multi-professional teams. For instance, in the setting of the standard for the best practice tariff for fractured neck of femur, where anaesthetists, care of the elderly physicians, orthopaedic surgeons, nurses, physiotherapists were involved in setting a standard of care, and that was backed up with finance, because when you set a best practice standard, actually you're rewarded financially, so there's a real buy-in from everybody and the trust and so on. Then you actually see very quick change, which has proved to be fantastic for the patient. We've seen death rates at 30 days for fractured neck of femur absolutely plummet in the last year, because we have changed the way we will deal with this particularly frail and vulnerable group of patients. So I think it is for the professional people to actually be at the heart of setting the standards, and to, if you can get somebody to buy into that with actual money, that's even better.
Moved on to the issue of not just standard setting, but how they're going to be achieved and how quickly.
Can I just pick up Alistair's point first of all? Yes, it should be public and patient involvement. You'll recall that we had public and patient involvement forums for a while, then they disappeared. But I think all of this patient and public involvement movement has suffered from a lack of clarity when the CHCs were closed down, something new was started up. My experience is that those bodies that are set up formally to do that kind of thing struggle with challenging PCTs, SHAs, acute hospitals. Moving to Cure the NHS, where we came into a very focused patient and loved one group with a very powerful driver for change, was that it was much easier. And it strikes me that groups like Kieran's Patients Association do not have the trammels of things like patient-public involvement forums, links. They can set their own agenda. They can be very clear about what they want to say. All the social interactions around being a member of a group that interrelates with something like a hospital board is a great dampener. And we found at Stafford, of course, that the PPI forum, choose my words carefully, did not help to expose the poor standards there. I'm sorry, but I'm not sure that Health Watch is going to be much better. If I could just come on to your aspirational standards, Anthony's already touched on it. There's really only one standard for a lot of healthcare, and that's zero harm. It goes back thousands of years to Florence Nightingale. First, do no harm. Why do we set numerical standards for some of these things? Should be zero. Doesn't mean zero errors. Humans make errors. And one of the things that Anthony did, as soon as he came to Chief Executive of Stafford Hospital, was adopted that as a way forward. Zero harm.
Zero harm. Very good. And you had a point as well.
I've got three very brief points, honestly, three very brief points on the third question. It's implicit, we need to remember if it's implicit in the question that standards not being complied with are a failure of regulation, it is actually a failure of regulation if that's true, and also a failure to meet the standards by the people that have got the responsibility. And I would urge you to make sure you look at the two together rather than separate them, otherwise you won't come to the right thing. Standards, we had homework was on standards, and I asked the question what's meant by it, and I was told it means 100 things. One of the things that strikes me about the conversation is, are standards means or ends? It strikes me that in a good operating regime, they are means rather than ends. And if you put that together with continuous improvement rather than aspirational standards, you can then, I think, start to construct something sensible, better.
Very good.